Good morning, respected learned dignitaries, seniors, my dear colleagues and dear friends. Today we are here for the 27th CPC of our institute, which is one of the most prestigious academic activity of our institute. Now CPC is just not a case discussion, but it is where your clinical reasoning meets scientific evidence and you sharpen your skills in diagnosis and managing the patient. So today's CPC is by a department that deals with the tiny messengers that circulate in your body and play a pivotal role in changing your lives both in health and disease, that is hormones, the Department of Endocrinology. So without much ado, let's begin this session. With this, I welcome onto the stage. We'll be joined by our principal sir later. So let's welcome onto the stage first the convener of CPC, Dr. Puneet Saxena sir, the brainchild behind starting this CPC. And he has been a big motivational force. The next motivational force and who keeps the CPC going, the co-convener, Dr. Jain ma'am. Please ma'am, come onto the stage. And then, now I welcome the senior professor and head of department of today's program, Dr. Sandeep Mathur sir. Yes sir, that's a new knowledge sir for me. Yes sir. So unfortunately we will not be joined by our beloved principal and controller sir. So with this, as per the dictum, let's begin the CPC. So first we'll have the SOP of the CPC by our convener, Dr. Puneet Saxena sir.
Good morning everybody and welcome again to this episode of CPC. So SOP we all know. So I can see many HODs sitting over there who have already presented and the faculty members must have seen so many CPCs, so we don't have to repeat that. But just a request that we need to strengthen the attendance. Time and again the attendance falls. So whenever we reinforce, then it comes and then again it falls. So I just request that the attendance and the time should be respected so that it can be enjoyed. Basically, the presenting department puts in so much of effort to present the CPC, so it should be for benefit of all. So with that, today we'll have CPC from Department of Endocrinology, and we are going to see a very good or unique and rare case which will touch upon many specialties. And the next will be done by radiation oncology. I don't think there is anybody from radiation oncology. You are there, so please convey it to your HOD so that you have in month of May, that would be 15th of May, right? So with that, I hand over to Mathur to carry on the activity.
Now I welcome onto stage Dr. Sandeep Mathur sir to give a brief intro about his department.
Thank you very much, Puneet, for this opportunity. Happy to see bright faculty Mathur to introduce me. Thank you. Actually, endocrinology department unique in the sense it is a clinical department with all requirements we have as per NMC norms and clinical services. But unique in the sense we have equally important basic science research wing, which is out of box and out of requirement of NMC. So I will introduce both of them. So the foundation was laid in 1997 by me, appointed as assistant professor. I had to work in Department of Nephrology. Many people know that era when I was working in nephrology, then in medicine department. And in 97 to 2005, so basic clinical services were started like OPD as well as reference service. And clinical endocrinology unit was established in 2005. Again, me as associate professor and one faculty and two medical officers. And in fact, in 2013, thankfully Dr. Balram, he agreed to join Department of Endocrinology with Mukul Gupta as assistant professor. And the unit was established, strengthened, and DM course was started with full faculty, at least for the one unit. Between 2005 and 13 was the era of multi-dimensional expansion of super specialty, right from establishment of basic clinical service, indoor, outdoor, and all this thing, to advanced laboratory. Actually, the strength of our department is we have an advanced laboratory even for the clinical services. Forget about basic science research laboratory, which is a unique thing for our department in the country and one of few in the world, in fact, in the endocrinology department. And in 2013, a unique molecular genetic research lab with the help of Government of Rajasthan. And I'm really thankful to Government of Rajasthan. As a budget announcement, it was established. It was first so in any endocrinology department in the country, and possibly even today, no endocrine department in the country like AIMS, PJ, and all others, they don't have their own molecular genetic research facility. Currently, we have 4 faculty members. I'm happy to share Dr. Anamika Gora has now joining us. She is Chief Dr. RPSC selection process. I think very bright faculty. Dr. Balram, very bright faculty. Sanjay, bright faculty. And now Anamika has joined us. I hope they will carry forward the mission which I initiated. So in 2023 and 4, we were upgraded by a budget announcement of the CM as a Center of Excellence for Advanced Care in Research. Actually, it is a misprint here. Not only clinical but endocrine research also. Inherited hormone metabolic disorder. First time in the country, our center is Center for Inherited Hormone Metabolic Disorder. They are rare disease, but they deserve attention. We have OPD service like all department, 1.25 lakh patients per year. We have indoor facility, we have academic with DM course, all the usual things. But our strength is our clinical laboratory. We have at least 3 to 4 actually hormone assay system. We have all ELISAs, biochemical analyzer and all these things. 35,000 tests are performed, 45 parameters. Biochemistry has I think 25 parameters for hormones, and we have 45 parameters. And we are the second one in the country for our own LC-MS facility, and we have osmolality measurement facility also. So our department, no patient has to go out for any private lab. We are doing all investigation in our own department in-house. And I want to tell you the faculty that every department should have a strong laboratory wing, should do deep clinical phenotyping if you really want to grow up in molecular science or any other discipline in the world and you want to have international publication. And there are several awards. I was given Commonwealth, prestigious Commonwealth Award in 2003, and I had been to Imperial College London to have training in molecular genetics. And Travel Award by American Association of Endocrinologists to me. And our is the, I think, one of the few department, small department. Me and Dr. Balram both were given actually State Merit Award. And congratulations Balram, he won this 2025. He was honored with this State Merit Award. And I was given this in 2018. There are several orations I have given in the country, like all prestigious national oration and state orations I have been giving. Our strength is molecular genetic lab. We know it's come on the way to your canteen. Actually, established in 2013, we have basic research facility that was required at the time of 2013. Of course, NGS is to be developed, it is in pipeline. We are some major achievements in the science and the clinical translational medicine. Molecular genetics, hormone metabolic disorders are the main agenda. Asian Indian thin fat phenotype. Actually, we have decoded why Indians thin fat develop diabetes mellitus even when they are not obese. In fact, people from even President of European Society for Obesity Research wants to work with me now with the basis of our work, rather than we are applying for support, and we are submitting joint proposal. Even we were funded by actually Framework 7 from plan from European Union. Unfortunately, because of legal issues, they were not materialized. And we are the pioneer in the world to give the lipodystrophy is a rare disease and type 2 diabetes is a functional defect of that lipodystrophy syndrome. It's a novel concept in science. And we are working actually on the genetics of all hormone and metabolic diseases. So we want to develop the atlas. I'm coming some more achievements in the lab. We have working culture, only one scientist whom I pay from my own sources and 2 technicians. And actually this lab is open to all institutions for their students to come to do their thesis. And we will be happy to help them. Anybody can come and work in our lab. And of course, we have collaboration with top lab of the country like CIS, IGIB, CSIR and all those labs. And we have done many projects funded by ICMR, Metabolism and Molecular Society, CSIR. We have so many projects we have done funded by national prestige agencies. Still we have 3 more projects going on genomics. So endocrine tumor is a very important project which is going on. Hopefully we will have good collaboration with the European group. And we have, this is lab publication, not my department publication. We have a journal like JCM, we have diabetes, Nature Scientific Report, Frontiers in Endocrinology, Frontiers in Genetics, Frontiers in Clinical Diabetes, PLOS One, Journal of Human Genetics, Journal of Endocrine Society, Molecular Genetic Genomics. We have published in the top-notch journals in this field of molecular genetics. Some landmark publication. You see, we all know MBBS, even our 9th standard, Turner syndrome is associated with X chromosome. We were the first one in the world to say it is more frequently associated with chromosome 14. In fact, it's a new theory which has come out of this lab that Turner syndrome is associated with chromosome 14 defect. This is the common defect, and we are coming with a new disease entity which is already published, is Turner spectrum disorder. Turner syndrome is one of the many subtype of Turner spectrum. So this is the original concept from our lab. We were the first one in the world literature to show the roadmap how genetics susceptibility complex trait genes, so many genes ultimately lead to manifestation of diabetes and metabolic syndrome. So the roadmap was given, and in fact with 6 patient data, Nature Scientific Report published our work. This is a landmark and eye-opener how we can decode a complex state of diabetes and metabolic syndrome. We were the first one to show in that we talk visceral fat, subcutaneous fat, qualitatively they are the same at molecular level. The first time we give this concept to world literature. And one more thing, peripheral fat is worldwide in literature said, even many papers are still rejected by American journals, that peripheral fat is not playing any role protecting our diabetes and metabolic syndrome. We say no, it is the reverse. Peripheral fat is more important than your visceral fat, and this is we have shown at molecular level. So these are the some important outcome for our laboratory. And of course, we were in common media, so many news from us. I think our department is unique. There was never a negative report from my department so far from in popular media, and we have so many positive news. So thank you very much for your patience.
Thank you, sir. That was indeed a wonderful introduction, and we know how much of work you have been doing at the genetic level. So, coming to that, genes are no longer silent, and therapies are no longer one fit all. It is tailored according to individual's genetic code. Today's case is going to highlight the same thing. So, without much ado, I welcome the senior resident, Dr. Sherry Sapra from Endocrinology, to present the case.
Chairpersons, faculties, and colleagues, I will be starting with the case presentation. A 14-year, 10-month-old boy presented with the chief complaints of progressive weight gain, poor height gain since the last 2 years, and the complaints of stretch marks over abdomen and difficulty in getting up from squatting position since last 6 months. The patient was apparently asymptomatic 2 years ago when he started gaining weight. It was insidious in onset, gradually progressive weight gain of approximately 15 kilograms over the past 2 years. There's history of generalized progressive body swelling, predominantly affecting the face, front, and back of neck and abdomen. There is no history of increase in appetite. There is also history of poor height gain noticed by the mother since last 2 years. There is also history of stretch marks over abdomen since last 6 months. They are purplish in color. The patient also complained of difficulty in getting up from squatting position since the last 6 months. It was gradually progressive. There is no history of any exogenous steroid, Ayurvedic, homeopathic, or over-the-counter medication intake. There is no history suggestive of any visual, hearing, or cardiac defects suggestive of any syndromic causes of obesity. There is no significant past history. The patient's average daily caloric intake on the basis of his 24-hour dietary recall is approximately 1400 kilocalories per day. There is history of similar complaints of weight gain and concern for poor height gain in his younger brother. Coming on to the anthropometry, the patient's chronological age is 14 years 10 months. His height is at the 10th centile. His weight is between the 50th to the 75th centile. His height age is 12 years 9 months and the bone age is 12 years. His sexual maturity rating is appropriate for his age. On general examination, the patient had moon-like facies, a dorsocervical hump was present, supraclavicular pad of fat was present on both sides, acanthosis nigricans grade 4 was present over the neck and axilla, bilateral gynecomastia was present, and there was generalized obesity. The vitals were normal. Coming on to the systemic examination, in the chest examination, bilateral gynecomastia was present. In the per abdomen examination, purplish striae were present over bilateral flank region. In the CNS examination, the power was 3/5 at both the hip joints. The power was normal in all other joints in all ranges of motion. Summarizing my case, a 14-year, 10-month-old boy with progressive weight gain and concern for poor height gain for 2 years, with mooning of face, generalized obesity, bilateral gynecomastia, and features of protein catabolism in the form of purplish striae over abdomen and proximal muscle weakness of both lower limbs. Without any history of hyperpigmentation, headache, blurring of vision, without any history of exogenous drug intake, there is no history of diabetes or hypertension. My most probable diagnosis is endogenous Cushing syndrome. Now I'll be inviting my colleague Dr. Raj, third-year senior resident in the Department of Endocrinology, to brief about Cushing syndrome.
I will talk about diagnosis of Cushing syndrome. Cushing syndrome reflects a constellation of clinical features that result from chronic exposure to excess glucocorticoids of any etiology. Its clinical features include signs of protein catabolism like easy bruising, proximal muscle weakness, facial plethora, striae, and complications like hypertension, diabetes, obesity, PCOD, recurrent infections, and osteoporosis. These are mainly divided into two types, ACTH dependent and ACTH independent. ACTH dependent causes include Cushing disease, ectopic ACTH syndrome, ectopic CRH syndrome, macronodular adrenal hyperplasia, treatment with ACTH. And ACTH independent causes include adrenal adenoma, carcinoma, primary pigmented nodular adrenal hyperplasia and Carney syndrome, McKinnell-Brett syndrome, aberrant receptor expression. Other causes of hypercortisolism, which are known as pseudo-Cushing syndrome, include alcoholism, depression, obesity, and pregnancy. Diagnosis of Cushing syndrome includes three main steps. Step number 1, suspicion on the basis of clinical features. Step number 2, establishing the diagnosis of Cushing syndrome. And step number 3, establishing the cause of Cushing syndrome. In endocrinology, we first do dynamic tests to confirm the diagnosis. If there is hormone deficiency, we do stimulation test. If there is hormonal excess, we do suppression test. In Cushing syndrome, there is cortisol excess and the circadian rhythm of cortisol is lost. So first we confirm the diagnosis of Cushing syndrome. For that, we do screening tests. The screening tests available are number 1, late night salivary cortisol. Second number, 24-hour urinary free cortisol. And third, overnight 1 mg dexamethasone suppression test. Late night salivary cortisol is done to check the circadian rhythm. If other and 24-hour urinary free cortisol and dexamethasone suppressed tests are abnormal, it suggests cortisol excess. And to confirm the diagnosis, any 2 of the screening tests, at least 2 of the screening tests should be positive to confirm the diagnosis. In our patient, we perform late night serum cortisol, 24-hour urinary cortisol, overnight dexamethasone suppression test cortisol, and according to our departmental protocol, we also perform LDDST cortisol, which is low dose dexamethasone suppression test cortisol. In our patient, all screening tests were abnormal, confirming the diagnosis of Cushing syndrome. So next step, we proceed to find out the cause of Cushing syndrome. So for that, we first measure serum ACTH level. If it is suppressed less than 5 picogram per ml, it is ACTH independent Cushing syndrome. So in ACTH independent, we further proceed for adrenal imaging. If serum ACTH is in upper side and raised, it is, if more than 20 picogram per ml, it is ACTH dependent Cushing syndrome. For that, we perform pituitary MRI and other biochemical tests, which include high dose dexamethasone suppression test and CRH and desmopressin stimulation test. If in pituitary MRI, if the tumor size is less than 6 mm or if no tumor is seen, we proceed for the next step, which is inferior petrosal sinus sampling. And if tumor size is more than 6 mm and the biochemical tests support the diagnosis of Cushing disease, there is no need for inferior petrosal sinus sampling. The ACTH was 16 picogram per ml, which was not suppressed. And so we proceed to MRI. So MRI SELA, there was pituitary microadenoma of 3 mm size, and the HDDST was not suppressed. So we proceeded and referred to neurosurgery department for inferior petrosal sinus sampling. And other routine investigation and hormonal investigation were normal. Now I invite Dr. Dinesh Gupta, Radiology Department, to discuss further.
Good morning, respected dignitaries, faculty and colleagues. I will be presenting the radiological imaging findings. The triple phase CT of the abdomen reveals bilateral adenomegaly. The stem and medial limbs of bilateral adrenal glands appear globally bulky with a distinct multinodular contour. The dynamic contrast MRI of the sella turcica identifies a mildly enlarged pituitary gland with a volume of 599 mm3. The post-contrast imaging shows heterogeneous enhancement of the adenohypophysis, specifically featuring a focal hyperenhancing nodule measuring 3 into 3.6 into 3 mm in the left aspect.
Can you use the pointer?
Actually, you'll have to put it on the.
The previous one also.
वो लेना ही पड़ेगा.
You can use a pointer.
Yeah.
Yes.
Here we can see the multinodular contour of the adrenal gland, and in the right adrenal gland and the left adrenal gland. In the MRI dynamic, contrast that T1 posterior pituitary bright spot is maintained and the overall volume of the pituitary is mildly enlarged. In the dynamic contrast MR, we can see that there is a hyperenhancing nodule measuring approx 3 into 3.6 mm, where in the left aspect of anterior pituitary gland, mostly consistent with the pituitary microadenoma. There is also a T2 hyperintense midline reticular cyst. The scrotal ultrasonography demonstrates bilateral diffuse testicular microlithiasis, which appear as variable sized echogenic foci with acoustic shadowing with a hypoechoic parenchyma. The right testis volume approx 3.6 ml and the left testis measured approx 6.4 ml. Concurrently, the screening ultrasound of the abdomen was unremarkable for solid organ pathology. Ultrasonography of the bilateral breast confirmed bilateral gynecomastia, characterized by the presence of organized fatty fibroglandular tissue. On the left, this tissue measures approximately 47 into 14 mm, and on the right, it measures approximately 41 into 11 mm. There were no discrete suspicious masses, cystic components, or architectural distortion noted within the breast parenchyma. Now, I would like to invite Dr. Ashok Gandhi sir, Senior Professor, Department of Neurosurgery, to talk about inferior petrosal sinus.
So, inferior petrosal sinus is a sample driven from the inferior petrosal sinus, and we measure the ACTH level to confirm that there is a increased ACTH level or not, to confirm that it is the source is the pituitary or other source. So for that we puncture the three vessels. One is the femoral artery of the right side and the two femoral veins, right and left, and put three short femoral sheaths inside the vessels and take the three diagnostic catheter to the internal carotid artery or two jugular veins. For that, first we put the internal carotid artery, take this angiogram to confirm that the vessel anatomy is normal, and we also can see the inferior petrosal sinus of the both sides. Either it is sometimes, rarely it is hypoplastic or absent. In for this inferior petrosal sinus, drain the cavernous sinus to the jugular bulb, and when we reach to the jugular bulb, we forcefully inject the dye so that we can see the inferior petrosal sinus, and we can convert this angiogram into the road map. And after converting into the road map, we can advance the wire into the inferior petrosal sinus, and over the wire we can advance the catheter into the inferior petrosal sinus. And after advancing to the inferior petrosal sinus, we confirm the correct placement should be at the junction of the cavernous sinus and the inferior petrosal sinus, as much as near the cavernous sinus. So, these diagnostic catheters should be placed bilaterally in the inferior petrosal sinus. And question arises why the bilateral sample should be taken. As the pituitary has the left and right half, and most of the ACTH secreting tumor are the microadenoma, and which are placed peripherally. And each half of the pituitary gland is drained by the ipsilateral cavernous sinus. So one of the petrosal sinus has the increased value of the ACTH. That's why the bilateral sampling has to be taken. And if the catheter, we take the angiogram, and if in this case our catheter is in the vertebrovenous plexus, which is a wrong placement, and if we draw the blood sample from this side, the value should be, or value will be wrong and diagnosis will be incorrect. For drawing the blood sample, we require the 3 persons simultaneously, so they can simultaneously take the blood sample these are the 3% which are taking the blood sample. So we take the sample at -5, 0, 5, 10 and 15 minutes. Before the stimulation, the 0 and 5 minutes, and after stimulation 5, 10 and 15 minutes. For stimulation we use either most ideal candidate is the corticotropin releasing hormone, which is not available or very expensive. At our institute, we can either use the vasopressin or desmopressin, which are available. And we use vasopressin because it is in the hospital stock and it is a very low cost. And it is much more potent than the desmopressin. That's why we use the for ACTS stimulation, the vasopressin. Then we take the basal value, that is the 0 and 5 minute value of the peripheral as well as the inferior petrosal sinus. And if you inferior petrosal sinus, that is the highest value, compare with the basal value of the peripheral. If it is more than 2, then it is a Cushing disease. And if post stimulation, if the value is more than 3, then again the Cushing disease. And if these are below the threshold, then we can suspect the ectopic ACTS. And if we compare both the right and left side, if it is more than 1.5, then it is localized to that side of the pituitary glands. So IPS is indicated only in 3 scenarios. One is the small pituitary gland, that is microadenoma with low dose dexamethasone or high dose dexamethasone suppression test are equivocal or not pointing to the pituitary. Either or in the MRE negative or where we need the lateralization. In these 3 scenarios, we need the IPSs. So I invite the next speaker.
Good morning, everyone. So in our patient, the IPSS results were suggestive. At post-vasopressin 10 minutes, the results were 12.13. As sir has already been discussed that if post-stimulation it is more than 3, then it is suggestive of Cushing disease. So on the basis of above all these results, in our differential diagnosis, some points are in favor and some points are in against. So in Cushing disease, points in favor are ACTH normal to high, MRI cell was suggestive of pituitary microadenoma, IPSS post-stimulation at 10 minutes was more than 3, and CT abdomen was showing bilateral adrenal hyperplasia, which can be present in Cushing disease. And point against was high dose dexamethasone suppression test was not suppressed in RPS. Points in favor of ectopic ACTS syndrome was CCT abdomen was showing bilateral adrenal hyperplasia, and point against was there was no clinical and biochemical evidence of the ectopic sources and no imaging features suggestive of ectopic sources, and IPSS post-stimulation at 10 minutes was more than 3. Points in favor of adrenal dependent Cushing syndrome was high dose dexamethasone suppression test was not suppressed. CT abdomen was showing bilateral adrenal hyperplasia with nodularity, and point against was ACTS 16 picogram per ml, which was low in case of point against was ACTS 16 picogram per ml. In adrenal dependent Cushing syndrome, it should be less than 5, and presence of pituitary microadenoma, which can be incidental and misleading. So most probable diagnosis is ACTS dependent Cushing syndrome due to pituitary microadenoma and hyperplasia. However, other diagnoses are not ruled out with full confidence. So, the current and accepted standard treatment in this clinical scenario, if any patient is presented with Cushing disease, then we should go for transsphenoidal surgery. And if patient is having microadenoma, there are higher likelihood of remission. If patient is having microadenoma or invasive adenoma or no visible adenoma, then lower likelihood of remission. Post-operative, if patient is having no remission or recurrence, then the management will depend on multiple factors, and it is a very complex cascade. Disease remission rate is seen in 80% of the cases in after initial surgery, and if we do transsphenoidal pituitary surgery, then reduced remission rate is to 58%. So Cushing syndrome is a very complex disease. So I would like to invite our HOD, Dr. Sandeep Mathur sir, to enlighten the role of genomic medicine and genomic techniques in this case.
Actually, it's a very common, complex situation for us. Majority points, findings points pituitary cause, as in this case, but we are not 100% confident, as highlighted by Anamika. But standard practice, we go for transsphenoidal surgery because gradient was 15-fold in the IPSS, even after stimulation, for 5 times than we expect. So natural course of action was, by logic was, transsphenoidal surgery. But what happens many times patients don't recover. At least 30-40% patients, they come back with persistence of disease even after surgery. Second surgery, even failure rate is high and the patient suffer very badly. You see, intracranial pituitary surgery, failure, then surgery, very actually great suffering from the patient. Now I enter the arena of my research, translational research is genomic medicine. Can genomic testing help?
Dr. Sandeep, can I ask a question?
Yeah.
Initially, I think there was some discordance as far as the ACTH suppression was concerned. And secondly, what is the role of ABS in this patient? You are suspecting second location that
you know, dexamethasone suppression test, which is high dose dexamethasone suppression, that was the only point against the diagnosis. That was the only point against the diagnosis of pituitary cause. But sensitivity is the test is only 60 to 70%. That is not 100%. Suppose that high dose dexamethasone suppression test sensitivity is 100%, we should have ruled out pituitary cause. There was no need for IPSS. But there was microadenoma. Sensitivity of high dose dexamethasone suppression test is not 100%. Sensitivity is 100%. Specificity is not 100%. That's why it is very time happens we don't reach a conclusion. So standard protocol go for all the tests. At least if ACTH value is in the borderline range. Because ACTH was 16 and you know in our assay system 16 means it is 20-25 because sample are supposed to be taken in eyes to be transported in. We do all those things. But 16 is quite high to rule out adrenal cause at least. Because adrenal cause it will be definitely suppressed less than 5. The issue is differentiating between ectopic tumor as well as Cushing disease from pituitary. That's why we are supposed to do IPSS. That is the only diagnostic test. Ectopic tumors, we look into the lungs and all the organs of the body, abdomen. There's such a small tumor, they are not picked on imaging. And we can't do blood sampling from like your intestine and leg and everywhere because that can be situated anywhere in the abdomen and thorax. So ectopic sites are very small tumors. They are 99% missed on imaging. That's why we have to do IPSS in this patient. And IPSS was pointing towards actually, even the catheterization was not proper, even 15-fold higher values from pituitary, coming from pituitary, veins coming from the pituitary, points toward actually pituitary origin of excess ACTH.
My point was, which is the most common after pituitary, which is the next common site?
Ectopic. Yeah. And third is your adrenal.
So that's what I'm saying. The second, adrenals are hyperplastic. So what is the role of adrenal vein sampling in this patient?
First take my
inferior petrosal sinus sampling was not adrenal venous sampling was done.
No, adrenal also. To rule out the adrenal, you can just do adrenal vein sampling also. If you want to localize to the adrenals.
Actually, sir, the ABS is the only modality which is used in the Conn syndrome diagnosis. It's never used in the diagnosis of adrenal source of Cushing disease or Cushing syndrome. So ABS is never a modality to be used for the diagnosis of adrenal Cushing. It is only used for the Conn syndrome.
No, let me actually one more thing, very important fundamental point. Adrenal hyperplasia is the effect of excess of ACTH. It is not ACTH coming out of adrenal gland. But what he is confused that ACTH could be coming out of adrenal gland. It never happens. ACTH stimulation causes bilateral adrenal hyperplasia. Suppose you do a sampling from adrenal veins, you will not find anything because there is no ACTH producing tumor in adrenal gland. Adrenal tumor is cortisol producing tumor. That's why this is never in our guidelines. Go for adrenal.
Both ways it can.
Yeah. Anyway, now coming to the difference between genome. So, with this background, I am coming to genomic medicine genetics. Most people don't understand the difference between genomic medicine and genetics. Genetics is study of one gene. It is an old science. Monogenic disorder, one gene, you sequence that gene and see if defect is there or not. It's a complex story. But genomic medicine means sequencing the whole genome. This is 3:10⁹ size. Data is there and pinpoint what is the cause of your clinical manifestations. So, this is background of genomic medicine. Now I looked at Cushing syndrome, otherwise hormonal disorders, with what are the genetic susceptibility genes. But I'm interesting to see CNS disease, there are certain genes which makes a person susceptible. Regarding ectopic ACTH, which could be a lung tumor or anything else, which could be a very small tumor, there are certain genetic susceptibility genes are there. And all adrenal disorders, there are certain susceptibility genes are there. So my thought was, why not to go for genome sequencing directly? So keeping in view potential role of genomic variants of several genes in causation of all three categories of disease which can cause Cushing syndrome, and ACT dependent, independent, pituitary, ectopic, adrenal cause of Cushing syndrome, we decided to go for whole exome sequencing. You see, if we talk in the era of Cabot in Massachusetts Journal Report in 1920-30, biopsy was the final diagnostic gold standard. Now we want to enter in the arena. Genome sequencing could be the gold standard. If it is gold standard, why not the first line test? This is the thing I want to highlight and the thing which we want to work on. So going for the genome sequencing results, so I will pause Dr. Gayatri. She is Professor, Department of Medical Genetics, to present here the results of whole exome sequencing in this patient.
Thank you, sir. Good morning to all respected teachers and my colleagues. I will speak about the whole exome sequencing report of this patient. Basically, in the whole exome sequence report of this patient, we have detected the pathogenic variant in the gene KAR1A gene, which is located on the exome 5. And basically, variant was detected in C stand for coding. Coding region, there is 2 deletion at the position 491 and 492. So what are its effect? P stand for protein. So in protein, at position 164, the initial amino acid was valine, which is replaced by aspartic acid. And there is termination after 5 codon. So basically, this mutation has lead to frame shift mutation. So in this case, the protein which is produced, it is truncated. So it is pathogenic. And in OMIM classification, this genetic defect is categorized under the category of primary pigmented nodular adrenocortical disease. It is inherited in autosomal dominant method. In ACMG classification, it comes under category of pathogenic. And by doing this whole exome sequencing, we are able to confirm the diagnosis of the patient. So we can also assess for the other systems which are involved in this disease, and parental testing is recommended to know whether the disease is de novo or inherited. Now I will briefly explain about next generation sequencing. Basically, in next generation sequencing, we can test for single gene, like in sickle cell disease. We can go for targeted gene panel, exome sequencing or genome sequencing. In targeted gene panel, we go for some of the genes which are associated with particular conditions. Like there are some genes which are associated with epilepsy, autism or development delay. So it covers around 10 to 500 genes. Accuracy is high, and there is a rapid turnaround time, and it is cost effective, and depth is more than 500x. But we may miss some rare genes in this targeted gene panel. Then exome sequencing. In exome sequencing, basically we are seeing the exome part of the DNA, which is the which code for the genes. And we know that exomes constitute about 1 to 2% of the whole genome, but 85 to 90% of the defects are located in exome. So in this, the entire exome is covered, that is 20 to 25,000 genes. Accuracy is good, and reports come around in 1 month. It is cost effective, and depth is 50 to 100x. Then higher up we can go for genomic sequencing. In this, all genes and known coding region of the disease are covered, but accuracy is low because we are seeing the whole genome. And time it takes around long turnout time. It is most expensive, and depth is reduced, that is 30x. So while ordering test, we have to keep certain things in mind, that like in exome sequencing, it covers exome, but there are some limitation of exome sequencing, like we cannot detect large deletion and duplication which are found in DMD, or if we are expecting some expansion, nucleotide expansion, like in Friedreich's ataxia or Huntington's disease, we can miss in exome sequencing, or there are defect in deep embryonic region of the DNA. So while advising NGS for patient, we have to very cautious to prescribe the appropriate genetic test. Now I will invite Dr. Priyanshu to tell about the effect produced by this gene mutation.
So good morning, respected seniors and my dear colleagues. So now I would like to talk about the key pathway which was affected in this particular patient. So we should know about the PRKAR1A gene. So what this gene normally does. So we should remember that it's a very important gene in the cyclic AMP pathway. So PRKAR1A gene encodes for a regulatory subunit of the protein kinase A, which is part of cyclic AMP pathway. So normal PK structure has two regulatory subunits and two catalytic subunits. The regulatory subunit is produced by the PRKAR1A gene. So in the resting state, PRKAR1A gene binds and inhibits the catalytic unit, so the PK remains inactive. So when cyclic AMP rises, cyclic AMP binds to PRKAR1A gene protein and catalytic subunits are released. That results in the PK become active. So PRKAR1A gene is a break in the cyclic AMP signaling pathway. And the key downstream targets are CREB protein, cell cycle, that results in gene transcription, cell cycle regulators, hormone synthesis pathway. So PRKAR1A gene ensures controlled cell growth, balanced hormonal production, and proper response to signals. So what goes wrong in the Carney complex? So in Carney complex, this PRKAR1A gene is usually mutated, and that is mainly loss of function mutation, and majority of cases it's a autosomal dominant, so haploinsufficiency is seen. And we should remember that one working copy is not enough in this particular condition. So that results in the reduced regulatory subunit levels, uncontrolled activation of the PK, and persistent signaling even without cyclic AMP. So this leads to the increased cell proliferation, abnormal differentiation, and tumor formation in this particular patient. So this is the summary of this entire pathway. So that almost all points are covered already. So family screening. So family screening is very important in autosomal dominant disorder. So in this patient, screening in mother and younger brother was done, and it is seen that mother was also having myxoma in heart, and overnight dexamethasone suppression test cortisol was 7.5, which was raised, and CT whole abdomen revealed bilateral adrenal hyperplasia. And in younger brother, which was 10 years old, so low dose dexamethasone suppression test was done, and cortisol was raised, and CT whole abdomen revealed bilateral adrenal hyperplasia. So there was a family history, but it was missed. So mother was also affected with the same defect, and other sibling was also affected with same defect. So now I would like to invite Dr. Jain.
So to reconfirm our diagnosis, we repeated the biochemical testing. We did the Riddle's test, in which we checked the baseline 24-hour urine-free cortisol, followed by the low-dose dexamethasone suppression test, and then the high-dose dexamethasone suppression test. In cases of PPNAD, this test characteristically shows a paradoxical rise in 24-hour urine-free cortisol, distinguishing PPNAD from majority of cases of adrenal Cushing who demonstrate no change. So we reached the final diagnosis of our case, that is Carney complex. The two major criteria for the diagnosis of Carney's, that is PPNAD and the characteristic testicular calcifications, are present in our case, and along with the PRKAR1A mutation, the diagnostic criteria for Carney's will be discussed later. The definitive management for PPNAD is bilateral adrenalectomy. We referred the patient for surgery, and we started the patient on ketoconazole in the intermediate period till surgery. Post-operatively, the patient was started on steroid supplementation. Now I invite Dr. Anshu Chaudhary, Senior Resident, Department of Pathology, to discuss the histopathology.
Good morning, respected teachers and colleagues. I will be discussing the histopathology of the case. So on gross examination, the left adrenalectomy specimen measures 7.5 into 3 into 2 centimeter and weighs 31 grams. And the right adrenalectomy specimen measures 6 into 3 into 1 centimeter and weighs 15 grams. So the outer and cut surface of both right and left adrenal specimen shows brownish to blackish discoloration and variable size nodules. And these are the nodules, And in between these nodules, there is normal adrenal tissue is also identified. On microscopic examination, the section shows variable size circumscribed adrenocortical nodules. These are circumscribed nodules with internodular compressed and atrophic adrenal parenchyma. On higher power, the tumor cells are large, polygonal, with abundant pale eosinophilics to finely vacuolated cytoplasm and round centrally placed nuclei and small nuclei. Some of the cells, they show variable finely granular golden brown intercytoplasmic pigment, which was lipofuscin. So, as the lesion was multinodular and the cell shows intracytoplasmic pigment, so the final diagnosis on histopathology was pigmented nodular adrenocortical disease. Now I would like to invite Dr. Balram Sharma sir, Professor Endocrinology, for further discussion on the case.
Respected seniors, so till now we have reached up to some difficult terminologies, and I'm sure that probably you are missing the terms pigmented or PPNet, Shelley mentioned, or the Carnage syndrome or Carnage complex. So the name denotes everything about this particular diagnosis, and here we can see that pigmented, we have just seen the histopathology that has a lipofuscin pigmented nodules sort of things. So the name is pigmented. There are multiple nodules in the adrenal. That's why the nomenclature is nodular, because it is at adrenal cortex. So again, adrenal cortex disease. So in short, we use the primary pigmented nodular adrenal disease. So this is PPNet. PPNet is in the short. So this is that rare condition that like Cushing itself is not that common endocrine disorder. But if we look at the numbers of the PPNet, so the total contribution of PPNet for the Cushing is almost only 1%. So you can imagine that how uncommon case we are actually discussing. So like in my career, I have seen only 4 or 5 cases of PPNet till now. We used to see Cushing almost on every week, but the PPNet is that uncommon. And here you can see that the PPNet commonly is familial. Almost 2/3 of the cases are familial, while remaining 1/3 might be sporadic also. And as I just mentioned, that it is contributing only less than 1% of total Cushing syndrome. So the hypercortisolism, which is the major thing for the Cushing, it is because of that multiple pigmented ACTH independent. So the point is ACTH independent. Here we were discussing about the pituitary, not like adenoma, and some changes in the adrenal were there. So there was a confusion, like the source is either the adrenal, as Dr. C.V. Meena sir asked, or the pituitary. So here this is pituitary independent or ACTH independent. So it is like functioning by itself, like the adrenal source is creating all the problems. So it is the pigmented ACTH independent functioning adrenocortical nodules which are the cause of the disease. And if we look at the presentation, most of them usually present before 15 years or so, but almost every patient is presenting before third decade. The signs and symptoms might be subtle, sometimes might be florid. Like in our case also, if you remember the pictures, they are not that florid. Like in Cushing, we see the florid pictures, but here the things might be subtle sometimes might be florid also. And sometimes they are like irregular also. And that's we used to label the term cyclical Cushing. Cyclical Cushing means at some time they are detectable biochemically, they have the high hormone level, at the other time they do not have the hypercortisolemia. So that's how they sometimes mimic the normal conditions, sometimes they mimic like the Cushing. So this is known as cyclical Cushing. So this is one of the cause of cyclical Cushing, also the PPNet. And because of those cyclical presentations, sometimes the presentation again is not that classical of the Cushing. And as we know that in kids or in the adolescents, the Cushing syndrome, or whenever there is hypercortisolemia, they usually present with the failure of in the growth. But here, because it is subtle, sometimes it is not that regular, this is cyclical also, so sometimes the height might also not compromise up to that extent. Like in our case also, if you remember, the height was at 10 centile. So that was not that reduced or slow down. But the diagnostic criteria or the classical test for differentiating the other causes of Cushing from the PPNet or this particular presentation is this test. This is known as the Liddell's test, as Shelly mentioned about that. So normally, as Raj also mentioned, that whenever we are looking for hypersecretion, means excess hormone, we use to suppress. That is called the dynamic endocrine testing, and this is the suppressive technology or strategies. But here, like in normal Cushing or in every other Cushing, if we are suppressing, then it is not possible. Like suppression is not possible. While in normal conditions, suppression is possible. So that's how we differentiate. This is hypercortisolemia. This is physiological. This is beyond the physiology. But here there is paradoxical rise. Means normally we are not able to suppress, but in the PPNet there is paradoxical rise. So the two days dexamethasone suppression test we use, and in place of suppression, this is actually rising. So there is a paradoxical rise, and this is a classical test to diagnose the PPNet, and that also was done in this case, and there was paradoxical rise in the urinary free cortisol. This image has already been discussed, that there are classical adrenal nodularity in the cortex. Here also you can see sometimes the pulse shape presentation is there, sometimes few nodules are there, or sometimes even the imaging might be normal, but still there are the nodules which are the cause for that. Treatment we have discussed already, that until the surgery is being done, we can use the pharmacotherapy like the ketoconazole to maintain the cortisol in the lower range. But the definitive treatment is bilateral adrenal resection or bilateral adrenalectomy, which was done in this case also, and we have seen the pathology pictures of that also. Coming to the broader picture, which is the Carney's complex. So Carney's complex is autosomal dominant disorder, which is having multiple neoplasia syndromes. Here there are various other conditions like cardiac myxomas are there, sometimes the mucosal or the skin myxomas are there, or sometimes the skin pigmentation problems are there, and the gene already has been discussed. So you can see there are various criteria, but the major criteria are either the adrenal nodules, which are the pigmented nodules, or the cardiac myxoma or the other myxoma, and the typical might be the skin or the mucosal lentigens, like the skin pigmentations are there. Sometimes the acromegaly is also there, sometimes the thyroid carcinoma nodules are there, sometimes schwannomas are there, and various more. Or the bilateral adrenal, bilateral gynecomastia is also there, like in our case. So if two or more criteria are fulfilled, then the diagnosis for the Carney's complex can be established. And here also we have the gynecomastia, we have the testicular calcification, so there were testicular tumors also. As well in the family, not in that case, but in the mother as well in the younger brother, there was cardiac myxomas also. So these all criteria were fulfilled, so the broader diagnosis was the Carney's complex here in this case. So if two or more major criteria are present, then diagnosis can be made, or this gene is present, then again diagnosis can be made, or the one major criteria is present with the family first degree relative is affected, then again the diagnosis can be made. And management already we have discussed that in PPNet we have to resect or we have to do the bilateral adrenalectomy, while if we look at the Carney's complex, then ongoing surveillance is required because various other problems are there. Particularly the myxomas are there, sometimes acromegaly is there, so we have to deal with that also because the cardiac myxomas sometimes might be fatal also. So that is one important point. And to conclude, I will again invite Shelly. Will you come? Or Dr. Mathur. Okay, thank you.
Actually, the whole purpose of this presentation was, my argument is, could genomic testing should have been the first line test in this case? We are not supposed to do invasive procedure, IPASS and all those things. Because genetic testing cost is slashing down. Now cost is 7,000 rupees. And if we do in private, because we are government otherwise free of cost, IPSS will cost a lot of money. So many imagings. And for searching for ectopic, so many imagings. So this case illustrates, should raise a question, should we go for whole exome sequencing first line test in Cushing disease? And we actually actually what I want to say in the final, this case illustrates that genomic medicine, otherwise called future medicine, has already percolated in the management of so-called pure hormonal disorder like Cushing's syndrome. Hence, we propose to investigate further if genomic test could be the first line investigation in the management of Cushing's syndrome and envision a global level impact on the algorithm in the diagnosis of Cushing's syndrome with genetic test as a first line test, particularly young patients. So this is our intention to, we are already actually collecting data and we want to at least see in retrospect. Could genomic testing first line test, Cushing's syndrome, screening test, diagnose, whole genome sequencing, point towards certain genetic variants, directly hit on that, not looking for everything by radiologically or by dynamic tests. And thank you very much for patience.
So one question.
Yeah.
Should we have gone for adrenalectomy of the mother and the other side?
Same thing will be done. In the mother and brother, they will also undergo bilateral adrenalectomy, and mother has myxoma also, she will undergo treatment for that also. Because by genetic testing, we diagnose myxoma also. Otherwise, we are going to miss that. So, genetic testing should come in priority in endocrinology, then dynamic test, radiology and all those things. This is the message I want to give.
I have a query. What is the commonest presentation of the Carney's complex? Because classically, clinically, you have a triad for Carney's complex.
Yeah.
So maybe the skin lesions or the myxomas and
if your dermatology is very astute, skin is a very common manifestation. Though our patient did not have skin manifestation. Skin is the most common.
So do we have a breakup of the percentage of the major criteria, which one is the commonest or maybe what?
I think Balram reviews this subject. Balram, a question is pertinent to you.
So do we have a breakup of percentage of the major diagnostic criteria that this is the most common thing, maybe the skin manifestation is the commonest, followed by the myxomas, followed by the Cushing's. So in how many patients?
Percentage is not actually mentioned, but the commonest thing is the cardiac myxoma common. The skin
manifestation, because classically what we have been reading in the textbook is the actually Carney described the syndrome not because of the genes initially, it was described based on the skin lesions, myxomas and Cushing syndrome. So
skin pigmentation is again pretty common, like the lentigens which I just mentioned.
Yeah.
They might be at the skin, they might be at the mucosa. And the cardiac myxoma, they are very, very common. And the PPNet, like I mentioned, that this is there, but that is not that common. But yes, it is one of the very important part of the cardiac.
Because there are cardiology people, if they have myxoma, they look retrospectively for Carney's complex. So in medicine also, if we find myxoma, so we also search for Carney's complex.
Yeah, in fact, if patient go to skin department lentiges, they should look for whole genome sequencing, see if positive, then other manifestations are there or not. Suppose lentage is there, they should do sequencing, genome sequencing, then look for myxoma by echo, and dexamethasone suppression test, because it's a cyclical Cushing syndrome. Might Cushing, but it is very dangerous in long term. You know, subclinical Cushing is much worse than your even metabolic syndrome in causing vascular metabolic dysfunction.
It was very interesting to know that alcoholism and depression, which are one of the most common problems in the community, for pseudocorticosis. So that and
actually I want to develop.
We are sending the samples for exams in college or outside.
Which
for this patient the sample was sent outside or it was
all the tests were in SMS excepting exome sequencing. Because
exome you are sending to Bangalore or
actually med genome process.
Med genome.
Actually, now we want to start in a big way. Whole exome sequencing, genome sequencing, target panel, everything is done in our institution. In fact, proposal already is Priyanshu will tell you. There is a budget announcement. Government want to do it free of cost to all the patients. And we have already submitted. They constitute a committee under my chairmanship for recommendation how the test to be done, whom should be done, and how financial arrangement and other things. I have already submitted report. Today it will be discussed regarding cost in RMRS meeting. What should be the coding for that, charges for the test. That will be decided today. And the next step we will go for actually laboratory service, hardware and consumables we will outsource. Interpretation result will be our. So there is an opportunity for our faculty, whosoever is interested in having, we want to organize workshop and courses here. Suppose you get lentiges and you get a genome sequence result of 3:10 to power 7 size. Okay, 3:10 3:10⁷ size, how to interpret that. I will be very happy to organize workshops here. Interpretation of genetic test report. That is our standard, that will remain with us always.
And for Dr. Gayatri there, so for whole genome sequencing, do we need consent of, does it have an ethical consideration for whole genome?
Yeah, there is a very important
for population strategy.
Sir, so this is a very good question, sir, because in India there is no guideline, but global guidelines are there. So we can't prescribe genetic testing in a patient less than 18 years of age, and we are not having clinical features suggestive of genetic disorders. So that's the only guideline. Which
it has an ethical issue.
Yeah, it's an ethical issue.
Because we are not supposed to report to anybody else. There are several variants which could be pathogenic, like to cause disease. They should never be disclosed to any insurance company or any relative of the patient, anybody else. Confidential is very important here.
Yes. So whenever we are suspecting genetic disease, only then we can send the samples.
Thank you very much.
So much for a beautifully concluded CPC, and congratulations from all present here as well as the team CPC for a wonderfully concluded and a crisp CPC concluded well in time, sir. Congratulations to the endocrine department, sir. And true, what was once silent and inside the cell has now become a key to unlock targeted therapies. So food for thought is, should genetics be as important as history and physical examination and replace as first line investigation? Thank you one and all. Join us for the tea and snacks.